Hello, my name is Andrea Brandi-Kitts, and I'm going to be speaking today on CT lung screening from a patient perspective. I'd like to thank ISLC for inviting me to speak at this symposium. These are my disclosures. None of them are relevant to my talk. Lung cancer is the second most common cancer worldwide. In 2020, there were 2.2 million new lung cancer diagnoses. It's also the leading cause of cancer deaths. We lost 1.8 million people to lung cancer in last year. The American Lung Association 2020 State of Lung Cancer Report shows that in the US, CT lung screening uptake rates are still low. Nationally, we average screening 5.7% of the eligible population, but there's wide variation state to state, with a high of 18.5% in Massachusetts down to 1% in Nevada. There's challenges for patients with screening. These include geographic accessibility to a screening site. We know that the availability of CT lung screening sites is correlated to the uptake of screening, but there's also challenges with transportation, getting time off work, insurance coverage, and English language proficiency. We know that having a regular source of healthcare is important. 80% of individuals undergo cancer screening because their doctor tells them to. Underserved populations are less likely to have regular healthcare and less likely to undergo screening. There's a lack of awareness of screening in the people at a high risk, as well as in some of the clinician populations. Lung cancer screening selection criteria are not always equivalent for risk between different populations. There's stigma due to the close association of lung cancer with tobacco use. There's distrust in the medical community, some due to the unethical practices in the past in research in the United States. Shared decision-making in the United States is an extra step, and it can be a barrier to screening. And many underestimate their risk of lung cancer. Often the harms are overstated and misrepresented. The most egregious misinformation is on the reporting of false positive rates. What is the false positive rate in modern clinical practice in CT lung screening? Is it 98%, 50%, 2%? All of these numbers have been reported in peer-reviewed medical journals. I'll have the answer in 2 slides. There is little to no evidence of patient anxiety with a positive scan. There's little to no evidence of permission to smoke with a negative scan. In the Lahey Hospital Medical Center, the participants in our lung cancer screening program actually had 2 to 3 times quit rates as the general population and 20 to 30 percentage point lower relapse rates. In long-term follow-up at the NLST, overdiagnosis was only 3%, and it was 0% for solid nodules. We found that significant incidental findings were 6% on the baseline scan and 2% on subsequent scans. So what are the false positive rates for CT lung screening? In the NLST, they were 23.3% over 3 rounds of screening. In a retrospective assessment of NLST using the LungRAD structured reporting criteria that's used in current clinical practice, over 3 rounds of screening, false positive rates were 7.8%. The baseline scan was highest at 12.6%, but then it was reduced to about 5% for the subsequent scans. The results of the screening of false positive rates in the Lahey Hospital Medical Center program were similar to the NLST reanalysis. These rates are similar to false positive rates in mammography. The 90% plus numbers that are reported in numerous journals are essentially the false discovery rate. The false discovery rate is false positives divided by total positives. That's not the false positive rate. False positive rate is false positives divided by true negatives plus false positives. It's also 1 minus specificity. One of the things that people say to me often when I mention the option for CT lung screening is, I don't want to know. Lung cancer is a death sentence. I'd rather not know. So what I tell people is I tell them, if you're in a screening program, it's not going to change whether you get lung cancer or not. But If you get lung cancer and you're in a screening program, 80% of the time it's going to be diagnosed at an early stage when it's more treatable. If you're not in a lung cancer screening program and you get diagnosed with lung cancer, 75% of the time it's going to be at a late stage when it's less treatable. This one-page decision aid shown on this slide is published in JTO in a CT lung screening review article. Hopefully it will be helpful for healthcare professionals to discuss screening with their patients. To help people understand their individual risk of lung cancer and to raise awareness about screening, Martin Tamimagi and I have worked with a software developer to develop the PLCOM 2012 Risk Calculator app. It's free to download, free of ads, and it does not store any user information. We provide it as a public service. We have a Spanish language version that's coming out soon, and for the European market, we'll have a no race version. These are available on both the Apple Store and for Android. Now, one of the major barriers to CT lung screening is the stigma associated with smoking. People fear the stigma. They fear anger from their loved ones and from others. I've had people tell me, my kids will hate me if I'm diagnosed. My spouse will leave me. People with lung cancer are blamed or blame themselves for their disease. The first question when someone hears about a lung cancer diagnosis invariably is, did he, did she smoke? Smoking was common in the 1940s through 1980s. This is a time when most eligible for CT lung screening programs started smoking. It was endorsed by physicians, sports authorities, Hollywood stars, and the government. Many clinicians practicing today were not around when smoking was glamorized and may not understand or empathize with their patients who continue to smoke or used to smoke. People who smoke say they are afraid of being lectured or made to feel stupid by their healthcare professional, and they may delay care, including delaying screening. There's something very simple that we can all do. Use people first language. A person who smokes, a person who used to smoke instead of smoker or former smoker, a person with lung cancer instead of lung cancer patients. And when putting together brochures and websites and marketing information about your CT lung screening program, use images expressing hope and empathy instead of pictures of smoking and cigarettes and dirty lungs and physical deformations. Those just reinforce the stigma and the nihilism. Disadvantaged populations experience double stigma, the stigma associated with their gender, sexual orientation, mental illness, disability, race, or ethnicity, in addition to the stigma associated with smoking. And there's healthcare provider implicit bias we need to account for, and differences in trust and perception of physicians. Systematic reviews show that smoking rates are higher in individuals with lower socioeconomic status. This is true in the developed world, but it's also true in low and middle income countries. In the US, almost half of people that have a high school GED use tobacco, and more than 25% of those living in poverty use tobacco. This is as compared to 20% of the general population. Groups that are at higher risk are Indigenous and Native populations and Blacks. They're diagnosed at a younger age and they have increased incidence and mortality. In the US, Black men have 14% higher incidence and 19% higher mortality as compared to whites, despite similar tobacco use. The US Plains Indian men have up to 70% increased incidence in lung cancer as compared to white men. 1/3 of Native Americans and Alaskan Natives use tobacco. Indigenous populations in Australia have about twice the incidence of lung cancer and twice the incidence of mortality as non-Indigenous populations. And in Ontario, Canada, First Nations men and women have 13% and 43% higher mortality, respectively, as compared to other populations. Age and smoking history don't capture everyone at equivalent risk. Blacks are less likely to meet current 2013 USPSTF criteria than whites. They're more likely to start smoking at a later age, smoke fewer cigarettes, longer duration of smoking, less likely to quit, and they're more likely to be diagnosed at an earlier age. In a Southern community cohort study of over 48,000 individuals in 12 states, Aldridge and colleagues found that fewer Blacks were eligible for screening as compared to whites. 17 in the full cohort, 17% of Blacks were eligible as compared to 31% of whites. And the subset of those diagnosed with lung cancer, almost 1,300 people, 32% of Blacks were eligible compared to 56% of whites. Blacks were diagnosed with a lower pack year smoking history and at a younger age. CT lung screening has a double benefit. One, finding lung cancer early when it's more treatable. And two, it provides a teachable moment to help people who smoke quit with significant health benefits beyond just lung cancer. The pandemic has highlighted the health disparity in underserved populations. We have a wonderful opportunity to improve the health of underserved communities by helping them to quit smoking. CT lung screening provides multiple touch points during the screening process, and we know that as little as 3 minutes spent on smoking cessation improves quit rates. The USPSTF 2021 updates to lung cancer screening recommendations lowers the age and pack year history eligibility. Age is lowered from 55 to 50, and pack year history is lowered from 30 to 20. This is going to improve screening. This is going to improve the screening eligibility disparity that currently exists for Blacks and for women. Now, one thing that hasn't been changed is it retains a 15-year quit limit. We know that 30 to 40% of diagnosed lung cancers are in people who have been quit for more than 15 years. So now the challenge is to implement quick coverage for the newly eligible population. This requires private insurance adoption and a CMS coverage determination. The new guidelines double the US CT screening eligible population to about 15 million people. CT lung screening programs need to prepare for that increased participation. The joint societies of the GO2 Foundation, the Society of Thoracic Surgeons, and the American College of Radiology have requested the CMS open the national coverage determination to look at the new USPSTF guidelines. They also request removing the 15-year quit limit and the upper age limits. And they revise the shared decision. They ask CMS to revise the shared decision-making criteria to stop it being a barrier. Private insurance has until January 2023 to cover the newly eligible population. We're planning advocacy at the federal, state, and local level to influence earlier coverage, as we know that early coverage will result in many additional lives saved. So what's the path forward? We need to provide CT lung screening where people live. So we need to implement outreach programs and provide screening in underserved communities. We know that underserved communities are at higher risk for lung cancer. We need to move quickly to get coverage in the US for the newly eligible individuals. We should include lung cancer risk prediction models in eligibility criteria, as they've been shown to essentially eliminate the disparity that exists for Blacks and for women. And we need education to address stigma and clinician implicit bias and nihilism. We should consider mobile screening units for rural areas. Use the UK Manchester and Liverpool lung health checks as a good model. We need to make it easy for doctors to talk to their patients about screening, provide them culturally appropriate materials and the tools they need to have the discussions. We need to create trust between patients and the healthcare professionals. Recruit minority physicians, nurses, and medical assistants to help address the overall patient's health. Really openly talk about the mistrust of the medical profession and also the fear and fatalism around cancer. And having personal testimonials from minority patients will help. We need to establish relationships with trusted community leaders and community members. We should partner with Native and Indigenous community leaders, develop relationships with national and local minority organizations, reach out and talk to community health workers who are part of their communities. We need to form multidisciplinary state, provincial, and local CT lung screening coalitions and learning collaboratives. We can identify gaps and needs and then co-design and implement interventions. We should position lung cancer screening as a health choice, similar to mammography and colonoscopy. Co-develop culturally tailored education materials and have public health campaigns that raise awareness about stigma and implicit bias. Globally, CT lung screening implementation is still in the initial stages. Unfortunately, CT lung screening is stigmatized because of the close association of lung cancer with smoking. Disadvantaged populations face double the stigma of their disability, race, or ethnicity, along with the stigma associated with smoking. The 2021 USPSTF screening guideline reduces disparity in eligibility for Blacks and women. Now we need to move to rapid coverage for everyone who's newly eligible. And we need to co-develop interventions with local and state provincial organizations to raise awareness, develop outreach programs, educational materials. We need to make sure that as we roll out this increased CT lung screening, that we don't increase the lung cancer mortality in disadvantaged communities. Thank you very much for coming to my talk.